Welcome to Critical Matters, a sound critical care podcast covering a broad range of topics related to the practice of intensive care medicine. Sound Critical Care provides comprehensive critical care programs to hospitals across the country. To learn more about our programs and career opportunities, visit www.soundphysicians.com. And now, your host, Dr. Sergio Zanotti.
The COVID-19 pandemic continues to grow throughout the world. The United States has now become the epicenter of the pandemic with a rapidly growing number of cases and deaths. Today's episode will focus on our discussion on respiratory support and mechanical ventilation with COVID-19. Recognizing that we still don't know enough about this disease and still unclear what would be helpful and what would be harmful, we thought that a discussion on what we've learned so far and how to apply these thoughts at the bedside would be timely. Our guest is Dr. Luciano Gattinoni, a true thought leader in critical care. Dr. Gattinoni is Emeritus Professor of the University of Milan. He is currently working as a professor at the University of Göttingen in Germany. He introduced the concept of lung rest by extracorporeal CO2 removal in acute respiratory failure. He pioneered the use of thoracic CT and ARDS, which culminated in the baby lung recruitability, and mechanical power concepts and theories. His research is focused on the pathophysiology and treatment of acute respiratory failure, including prone positioning, sepsis, and acid-base disorders. He has published more than 400 research articles and reviews in peer-reviewed journals. He has served as president of the European Society of Intensive Care Medicine, president of the World Federation of Societies of Intensive Care, Critical Care Medicine, and president of the Italian Society of Anesthesia, Analgesia, Reanimation, and Intensive Care. It's a true honor to have him as a guest. Luciano, welcome to Critical Matters.
Hi, everybody. Hi to everybody.
So I think that we are definitely living unprecedented times in terms of this COVID-19 pandemic really affecting every single country in the world and being, I think, in the forefront of our colleague intensivists day in and day out now. And I think that one of the things that I've noticed is that there's also been an explosion of information, an infodemic with good and bad information. But one of the reasons why I reached out was because I had seen in a lot of forums people posting thoughts and recommendations attributed to you that then when I finally was able to read a opinion piece that you had put in the Blue Journal, didn't seem to represent exactly what you were saying and thinking. But I do think that there are some very important lessons to learn about what we know about the lung disease that COVID-19 is producing. So Luciano, maybe we could start with just a basic review of our understanding of ventilator-induced lung injury and lung protective ventilation. And maybe you could just give us like a very basic overview on VILI and how you think about barotrauma, volume trauma, stress strain, and we can start there.
Okay, well, the ventilator-induced lung injury, as it's called now, has been recognized just after the initiation of the ventilation in mechanical ventilation, and was called barotrauma. Why barotrauma? Because about 50%, 60% of the patient had pneumothorax, pneumomediastinum, and so on. So the pressure used was up to 100 centimeters of water. Then with Dreyfus, this concept shifted from barotrauma to volotrauma, because Dreyfus, Didier said, okay, if I wrap the thorax with an inelastic substance, so I impede the dilatation of the thorax, I can use whatever pressure I want, there is no problem. It's the concept of the divers. You go down with a lot of atmosphere, you can go to 10 atmosphere and the land does not explode because you have 10 atmosphere outside. But the concept evolved to stress and strain, and basically, to make short and long story, the strain, which is I think is the fundamental part of the business, is when the lung structure is stretched over a certain degrees over its resting position. Resting position is a functional residual capacity. If I add a PEEP, I already strain in part of the lung. If I add the tidal volume, I strain even more. And what it appears quite consistent is that when the strain goes over the total lung capacity, not just for one breath, but for several breaths, and maybe for one day or several hours, the lung, you got the ventilator-induced lung injury, which manifests with what? It manifests or with rupture, if you have a stress or strain or rupture, or with an inflammatory reaction that we cannot distinguish from the normal ARDS, because you have inflammatory cells, edema, and so on. So, by the way, the last thing to remember is that the stress and strain are not distributed homogeneous into the lung, but are particularly important in the lung region where the elasticity is different. In these regions, the stress and strain are concentrated because one region or one structure expand more than the others. This is called focused stress, and is one of the problems of the non-homogeneity of the lung. So basically, the ventilator-induced lung injury is a strain of the lung above its physical capability, to which follows the rupture after days. But don't forget that within the lung there is one organ which is called heart. And we cannot speak about the lung if you do not consistently think to the hemodynamic, because anytime the lungs is hyperinflated or stressed, the heart is compressed, disappear behind the vertebral column, the venous return decreases, the kidneys start to suffer, and so and so. So I think in the concept of VILI should be integrated also the concept of the hemodynamic involvement.
So I think that to summarize for our listeners, Dr. Gattinoni, the stress really would be equivalent to the pressure, the transpleural pressure, right? And
that's right. Is the transpulmonary pressure which corresponds to a given strain. You cannot strain the lung without applying a change in pressure. So these are two faces of the same medal. And the constant of proportionality between stress and strain is called specific elastance. So that means the transpulmonary pressure or stress is equal to K, which is specific elastance, times, let's see, tidal volume plus PEEP volume divide the resting lung volume. This is the basic equation of stress and strain.
So I think that I have two questions, and the first question is that it is evident that no matter what we are doing with a patient or whatever syndrome they have, if they're on mechanical ventilation, considering ways to minimize the injury from stress and strain obviously is something that would help them clinically, right? As a basic concept.
That's right. But you know, I think that if you want to approach a rational mechanical ventilation, you have to know which are the lung conditions we start with. If the ventilable lung is very small, we call it baby lung. No? If it's very small, it's one thing. If you have a lung which a very large volume, is another completely different things. But the concept of stress and strain applied in both conditions. In one, you will have less volume to cause, let's call harmful strain. In the other condition, will be a larger tidal volume when we start with a larger resting volume. Unfortunately, nobody measured the volume, and nobody measured how much volume is due to PEEP. The PEEP is a pressure and rise up the lung volume. So it's easier with the tidal volume. Higher is the PEEP, is easier to reach the total lung capacity, which is the limit. You know, the literature is full of a protective effect of PEEP. But this protective effect of PEEP are due because the PEEP is high or because the tidal volume has been reduced. Because you don't see any protection when you rise the PEEP at the same tidal volume. At that point, may be a disaster.
And I think that's an important point, because a lot of people assume that high PEEP, independently of what else you're doing, might work or might not work. And I think that you're saying everything is really connected.
That's right. To me, I repeat, I have not the true in the pocket, but to me, this is a very severe mistake to consider that.
So
For the rest.
The second question, Luciano, I have regarding this whole concept of stress and strain and Billy is, what about people who are not on mechanical ventilation? Is there potential for lung injury by increasing stress and strain in somebody who has respiratory failure and is spontaneously breathing?
That's well, okay. Let me consider it. What does the mechanical ventilation? The mechanical ventilation substitutes the respiratory muscle, right? Does not substitute the gas exchange. Just substitute the respiratory muscle. So if instead of the energy provided by the ventilator, I provide a similar energy from the muscles, the question of stress and strain are exactly the same. Change the hemodynamic, but the stress and strain are exactly the same. In Ted Koloboff, well, in the 38th, Barak proved that very clearly. In 1988, Mascheroni and Koloboff was always 20 years ahead of the rest of the world, were injecting some acetyl acid in the cisterna magna of the ship, so the ship start to have a very big tidal volume, has to have a very big mechanical ventilation. In 24 hours, this lung had ARDS, perfectly in spontaneous breathing, with an airway pressure 0. But the transpulmonary pressure was huge. And now this concept has been rediscovered, revised, and so on by Brochard, Pesenti, and Slavsky when they describe the patient self-induced lung injury, which is extremely important overall in this COVID-19 pneumonia, I think. But you know, for the same transpulmonary pressure, if it's harmful, maybe it's exactly harmful in mechanical ventilation and in spontaneous breathing. The big difference between the two is the hemodynamic. With the spontaneous breathing, you suck the blood into the central system. With the mechanical ventilation, you squeeze out the blood from the mechanical system.
Yeah, and I think that those are important concepts, like you said, that we'll touch a little bit later when we talk specifically about COVID-19. But I think that to close this first segment, Dr. Gattinoni, when I hear people talk about lung protective ventilation, I think that most clinicians at the bedside think of two things. They think of small tidal volume, and they think of a plateau pressure below 30. That's kind of in their mind. And some people might think high PEEP, some people might think low PEEP. But that's kind of what people think. But really, from what I'm hearing you talk about, lung protective ventilation not only applies maybe to mechanical ventilation, but applies to any patient we're supporting, and really is about utilizing the tools we have available to minimize damage on the lung from stress and strain. Would that be an appropriate way of thinking about it?
Absolutely. I think what you have to think, the people is not accustomed to measure the pleural pressures, unfortunately. But what counts is the transpulmonary pressure, so the difference between airway and the outside of the pressure, which is equal to the stress. And then the basic concept applied equally. And the tidal volume ventilation protective, where we have the magic 6 milliliters per kilo, which is better than 12. Not necessarily is better than 8, depending on the compliance the patient starts with, you know. And the second concept, be careful with the hyper protective, because the people say if 6 is better than 12, 5 would be better than 6, 4 better than 5, 3 better than 2, minus 10 better than 0. It's not like that. Because if you go at a hyperprotective ventilation with, let's see, 4 of PEEP, the 4 of tidal volume, you look at the CO2 because you have a risk of hypoventilation. And hypoventilation, even if you use CO2 remover, is hypoventilation. That means the gas which arrive at the alveolar level are not enough. The oxygen consumed is much more than oxygen transferred from the air to the alveoli. That means after a while, this unit undergo in reabsorption atelectasis. So this is the intrinsic risk of the very low so-called hyperprotective. I think we should protect sometimes the lung from the doctors.
I agree. And I think that also what people, I think, fail when they don't understand, when we walk away from understanding the basic physiology, is that on average, if you took thousands of patients, because of what we've discussed, 6 mLs is probably safer in reducing the strain and associated with a lower stress than 12 mLs. But that's an average.
This is absolutely true. But remember to look always to the PCO2, because the PCO2 tell you the degree of alveolar ventilation we are dealing with. So the gas exchange is mathematical, you know. You have to consider all the variables at play, not just to oxygen or just the CO2 or just the frequency or just we try to introduce the concept of mechanical power in terms of Viri, which is the product is a variable which takes together the pressures, the volume, and the frequency. And what we found, at least experimentally, for a given damage is reached when you give a given package of mechanical power. Sometimes with lower tidal volume but very high frequency is just as bad as higher tidal volume with far lower frequency. Frequency is always forgot. But if I have a bad tidal volume, 10 per minus, 20 per minus, or 40 per minus, make a tremendous difference. But the people does not consider this one. Yeah. I think the mechanical power will gain some popularity. Not now, because now the people is busy with other things.
Yeah, it's hard to apply it to 1,000 patients at once, right?
Absolutely.
But I think it's important. I mean, no matter what's going on, to always try to learn from what we're seeing, so that tomorrow we could do things a little bit better. So let's.
Okay, but I think the mechanical power will be implemented in the ventilator.
Excellent.
So sooner or later we come out one number, joule per minute, and you know what is the energy we are putting in the system. Because
yeah,
all the data, all the numbers available in whatever modern ventilator.
And I think that also the interesting concept, I mean, that you said, like, frequency is always forgotten, but I think that also applies to clinical scenarios that I've seen. For example, people struggling with non-invasive, with a respiratory rate in the high 30s, and they kind of puddle along and probably causing tremendous amount of injury to their lungs. And then when they finally get intubated, we kind of wonder why they have such a bad outcome, right?
You know what I found terrible in a non-invasive ventilation is that theoretically the only difference you have with invasive ventilation is the tube. But with the non-invasive ventilation, you don't know anything of what you are doing. You do not know even how much is the tidal volume you are delivering. You do not have an idea of the transpulmonary pressure the patient is generating. To me, using the mechanical ventilation without the esophageal pressure that tell me how much are the swings of the pleural pressure of the patient is as to drive during the night in a foggy night without knowing where to go, maybe in a forest. Very dangerous.
So let's talk a little bit about COVID-19 associated severe acute respiratory illness. And I think that one of the observations that you and your colleagues have made is that there might be things that appear to be similar to what we call ARDS, which is also a syndrome, like we all know. But there might be some things that appear to be different, and that might have implications in the way we should be thinking or approaching these patients. So maybe you could just start by giving us a summary of what we know so far, and then maybe talk about what is similar to ARDS, and more importantly, what is different to other forms of ARDS that we usually treat.
Well, of course, I think I'm playing with ARDS since 40 years, but I never saw in a classical ARDS, let's see, severe ARDS, because this patient very often have a PF below 100, so they have an hypoxemia comparable with severe ARDS. They have some ground glass, so they have bilateral involvement of the lung, bilateral pneumonia, but the compliance is 60, 70, sometimes 80, in more than 50% of the patient while they do present. And I never saw something like that never. Maybe it occurs once, twice, but really is extremely rare, I put in this way, in a severe ARDS. If you go to the Bellani, the SAFE study, you see that even the mild ARDS, the compliance is always below 40, goes from 40, 35, 30. Here we have a median and a mean greater than 50. So this is the fundamental basis to start with. We have to sit down and to say how this is possible. Then we have a lot of CT scan of the patient, which are done very rarely. And let me try to tell you the story as I see the story, which I collect discussing with the nurses, with the colleagues from different hospitals in Lombardia, and after studying and examining a lot of CT scan data coming from my colleagues. Have you 5 minutes of patience for that? Hello?
Yes.
Are you there? Okay, because
yeah.
If we don't have the pathophysiology clear in mind, to speak about the treatment to me is a nonsense.
Yep.
So let's start in this way. The virus comes. What does the virus? While the bacteria affect mainly the alveolar size of the problem, and we have consolidation, capacitation, the virus interfere primarily with the vessels and with the endothelial cells. So you have vasoplegia. Vasoplegia, what means? What means that the regulation of the blood through the lung is lost. If it's lost, where the blood tends to go according to the gravity, which does not happen normally. We have quite homogeneous distribution of blood. So we have, due to this vasoplegia, which may originate from endothelial stimulation and so on, from many, many reasons, possible reasons, you have a tremendous VAQ mismatch. VAQ mismatch is a rather complicated physiological concept, but very briefly means that if one part of the lung I have a lot of ventilation and very, very, very small perfusion. In the other part of the lung, I have a small ventilation, a very, very high perfusion. What is the final result? If you play with the models, you may have tremendous hypoxemia, even with 60, 70, 80% of a shunt. And this hypoxemia at the beginning is very sensitive to oxygen. Now, when this patient go into the hospital, we have several patients, and this is consistent observation throughout the world, that come with 60, 65 of oxygen saturation, that means 35 of PO2, and do not accuse anything else but some fever, are not dyspnoic. Why? Because when you have this kind of hypoxemia, which is due to the vasoplegia, the brain, our center, react, activating, trying to increase the tidal volume, so increase the minute ventilation. Now, if you have a good compliance, if you increase the tidal volume, you don't have any dyspnea, because you make an effort and you find that the air coming into the lung is exactly what we expect for this kind of effort. It is clear, this concept?
Mm-hmm. Yes.
Dyspnea happens when you have some effort, I expect some amount of air, and I receive less.
Yep.
Now, let's see, I have a patient that come 3 days later into the hospital, and he stayed at home with this big breath. Big breath, what that means? Means big shift of pleural pressure, big negative pressure. And so we are back to tidal volume and to self-induced lung injury. If I have this, I start to have more blood, return blood into the lung. I have to filter more plasma, and the lung becomes more heavy, and so become more edematous. And the picture start to resemble to ARDS, because the compliance goes down.
Mm-hmm.
And from 70 goes maybe to 50. 3 days later is at 35. At this point, you are perfect picture of ARDS. And you see this perfectly well following with a CT scan with these patients. You see exactly the transition from what we call L light status, that means low VQ, low elastance, low lung weight, low edema, to the high status or high type, which is high elastance, which means low compliance, high volume, high lung weight, etc., etc. So at this point, I have some patient coming in a hospital which breathe normally without dyspnea. Some patient coming dyspnoic. Some patient coming severely dyspnoic. What they do have in common? They are all hypoxemic, because the hypoxemia is due to this tremendous VQ mismatch. At this point, if I have a gas which is full of, a lung which is full of gas, or a lung which is without, with a very small amount of gas and lot of edema, would you use the same therapy? Or in a lung full of gas, can you explain me why to use 15 of PEEP with a mask? One look at the PO2, if apply the PEEP FiO2 table, you end up with 20 of PEEP. With 20 of PEEP, you kill this patient, not all, but a good amount. Just to tell you something that me impressed a lot. I was called a couple of days ago from an hospital in Switzerland. They had a 40 patient with COPD, with COVID, and they were applying. As soon as the chef went to see the inspiratory effort, that means the negative pressure, the Siri, he was taking immediately the patient in intensive care, because they had a space for that, and was putting in paralysis and mechanical ventilation. So reducing this tremendous possibility of villi.
Mm-hmm.
And 40%, 40 patients all survived. In a hospital 20 kilometers close to there, they were applying similar amount of patients. They were applying the suggested guideline. So IPEEP, and then maybe delayed intubation and so on, the mortality was greater than 50%. In Athens, they told me the mortality was about 90%, applying the forms of ventilation that you apply in ARDS. Then you tell me the patients were different, the one were older, the comorbidity were different. But when you go from 0 to 50 to 90, I think we should, with extreme honest, intellectual honesty, ask ourselves, are we doing something dramatically wrong? This is the first question, before to say, no, these patients are different from mine because having said that, I think if I take a patient with 70 on compliance and I give a mask of non-invasive ventilation with 50, well, I have with 15, I have two possibilities. The idea would be to measure the inspiratory effort. But you can, okay, you don't have a esophageal balloon, you don't know how to use, okay. But look carefully. For 1 hour or two, what is the effort that the patient makes? If he starts to use some respiratory accessory muscle, if you have some ribs inflow, if you have a change in abdominal movement, if the patient is like this, you means that is continuing to induce a very big damage in his lung. At this point, I would suggest an immediate ventilation and paralysis. If the patient, very few, can support that, maybe you cut the vicious cycle, because if the patient continue, he will get edema. If he got edema, he will have greater inspiratory effort to keep the tidal volume. And so you have a tremendous picture. So I think if the patient is inspiratory effort associated with low oxygenation that does not respond to 5, 10, 15 or oxygen therapy, I think for what we know now to suggest immediate intubation and without any spontaneous moving of the patient. So or deep sedation or paralysis. Of course, the patient will improve the PO2. What you do when you start to see the PO2, which is good in ARDS? You start to win. If you do that with this patient after 2 days, you lose what you ever gained, because this disease, not syndrome, requires time. And until the virus has not been eliminated by our antibodies or some miracle, you cannot win the patient. The patient start to breathe as a hell and to have again dyspnea and then have again edema and so on. So this depend, to me, the therapy to be introduced depend on the phase that you see the patient and at what is the stage at the. Although I do not have the ideal therapy, I know what is wrong. In this condition, it's easier to do mistake doing something than don't doing nothing. You know, sometimes I wonder if the patient comes perfectly okay with 70 of saturation and 14 of hemoglobin. It's not different for the patient with 9 of saturation, 95, and 10 of hemoglobin, which are used in intensive care.
Yeah.
I should put a very strength in, or just to be patient and to observe and to think at the physiology and to try to measure whatever is possible to measure. I know that in front line is difficult, but you don't have to lose the entire paradigm.
And I think that a couple of things I wanted to dive deeper in, Dr. Gattinoni. Number one is, I think that something that we're seeing across the country and in our group, I mean, we have cared for probably over 500 COVID critical care patients around the country. And I think that that whole point that you made about patients is very important also as we're trying to extubate these patients. I think people are finding that if they extubate them too quickly, they often will get reintubated. And I think it just applies to a very basic concept that I think I learned as a medical student. If it takes you 8 days to get sick, it doesn't take you 2 days to get better, right?
Absolutely. I mean, this pneumonia lasts at least 15 days. If you pretend to extubate after 5 days, it's a disaster. Not only you have to reintubate the patient, but you have lost maybe 30% of the benefit you had before. And I know that to be patient, to do nothing is difficult in intensive care. Because in intensive care, the people is accustomed to, I turn it off, I see the result, I'm fast, quick, and rational. But in this case, to be rational, you have to be slow and quiet.
Yeah. And I think it applies also to other therapies, and something I worry about. We've all been taught in medicine, first do no harm, primum non nocere. And I think that when you are dealing with thousands of patients, anything that potentially could be harmful gets magnified at such a level that I think it's extremely dangerous. And I think that people are very anxious. And like you said, they feel that doing something is always better than not doing something. And I think that not only in our discussion with mechanical ventilation, but with all these drugs that are experimental, there's no proof that they work. I also fear the same consequences.
Let me lead to words about the drugs. Now, unfortunately, this patient, and overall in emergency, go through infectivologist, pneumologist, or somebody that never saw one ventilator and acute respiratory failure, and they were given whatever, with one result: antivirus, chloroquine, anti-L6, anti-L1, whatever. Okay, cortisone, yes, cortisone, no. The result with the antivirus that you kill the liver and you don't kill the virus. And I'm not aware of any drug which is effective. I think that these people, we have to wait for them. We have to have the research and some study that tell them, okay, this work or not. At the moment, I think the only thing that we can do is to provide nutrition to keep the patient alive as more gentle as possible and pay, I forgot this, as this is a vessel endothelial disease, is probably one of the most prothrombotic situation you can observe in intensive care. That means the microthrombosis, microthrombosis may be absolutely frequent, and also some macrothrombosis, as a frank pulmonary embolism or a brain damage with that. So I suggest a look at the D-dimer. When the D-dimer is greater than 2000, no, we start with a prophylaxis as double as normal, and we start with the anticoagulation when the tendency of the D-dimer goes up. Believe me, this is an extremely important. I lost my friend, one friend of mine, 10 days ago. He was recovering from pneumonia and he got a stroke. And all the patients, all the people who did the autopsy, they did at least, I had a report of 50 autopsies in Brescia. They had endothelial cells flowing in the blood and a lot of microthrombosis at the histological examination.
And I think that obviously that goes into also the whole idea of the VQ mismatch that we started the discussion with and what happens in this early phase. Two more questions, Dr. Gattinoni. So these phenotypes of L and H, the low and high, some people have presented that as two distinct diseases. From what I understand, you're really thinking that is one, it's a progression, right?
That's right. The one is the progression to the other. Sometimes the progression stopped naturally, okay? And some patients stopped at the status L. Some patient progresses to the status H. I think that some therapy helped to progress from L to H. because a wrong therapy will force the patient to have too many effort compare what is allowed in this condition. But I think that the picture I put in this I don't remember if in the editorial or in ECM editorial is the same patient 7 days apart.
Yeah.
And the 7 days were CPAP, a lot of respiratory effort, and very badly tolerate non-invasive ventilation.
Yeah. And I think that we can go a little bit deeper into some of the treatments, but I think that early on, obviously people have recognized that these patients are hypoxic, so the immediate reaction is you give them oxygen. And like you said, in many patients that's enough, and the majority of patients do better. Now, as the oxygen requirements keeps going up, the next step in our usual approach to these patients is to escalate there and either use high flow nasal cannula, high flow oxygen, or in some people they would use non-invasive. And I think that people have been focusing on the non-invasive mostly as something to avoid because they're worried that can increase the aerosolization of droplets and increase their risk of infection. But really, I think that the point here is that there's potential for more injury, there's potential for worse outcomes, and that has been suggested in some of the series. And now when you're making these pathophysiological observations, that makes sense. So it's not that you cannot use non-invasive, but if you use it within an hour, either it's better or it's a problem and you have to move to intubation. Is that the way to interpret?
My suggestion is you can try, but limit the time, and please be extremely careful to the minimal sign of inspiratory effort the patient is made. The idea would be to put an esophageal pressure, but nobody put esophageal pressure in the peacetime. You can imagine the wartime.
Yeah. Not practical.
Okay, but you know, sometimes the people transfer the patient with helicopter is more practical to put esophageal pressure inside. Anyway, is to me, what we can do in terms of not harm is to avoid the patient patient inflicted, self-inflicted lung injury. Silly, this way, okay? Which is a whole story. So at whatever side that this patient may generate silly, you have to intubate, paralysis, and keep for the time sufficient to heal.
What about high flow oxygen, Dr. Gattinoni, and the concept of dead space in these patients?
Well, you know, the dead space, anytime you have the acute demand distribution, you have, of course, if you have low ventilation in one part and high perfusion, in the other part, I have high ventilation and low perfusion, which is read as a dead space. Plus, there is the possibility of microthrombosis. But remember, this patient at the beginning, I don't think they do have in general microthrombosis because they come with a PCO2 25, 30, 35. When the PCO2 goes up, that means that the structure of the lung starts to modify. I am more afraid from the rise of PCO2 than from decrease of oxygen, because the PCO2 change reflects the structural change of the lung.
Yeah. And I think that's also something analogous to what we've seen in ARDS. Patients can tolerate hypoxemia. I mean, you can go to the top of Everest and have a PO2 that's very low and come back down. You're not critically ill, but still, even in critically ill patients, we've seen that. But when you can't ventilate somebody, like you said, it reflects that there's been a change in the lung, and that's usually a very bad sign for that patient.
Yes. Yes.
So let's talk a little bit about how you would approach them once they get intubated. You talked early on, especially in this low phase, early on, that you would obviously deep sedation if possible, paralysis, and make sure that you're looking at. But
in a patient with which manifests some effort, okay, because if the patient does not manifest any effort, maybe may tolerate easily, but this patient has to be observed carefully. The worst is that for reason of lack of beds offer a lack of attention from the doctors and nurses, the patient stay 2-3 days having a big inspiratory effort in spontaneous breathing or even in non-invasive mechanical ventilation. This is the point. The motor is the behavior of the pleural pressure swings that you don't see, but you have to imagine that do exist.
Yep. And I think that that's a good point that we have traditionally not really applied or thought about. And I think in terms of current recommendations, Dr. Gattinoni, I think that you could still fit these into a rational way of approaching this. And I think that people recommend that we use lower tidal volumes in general, 4 to 8. Doesn't mean that everybody should be 6. So for example, if somebody has a good compliance, maybe 8, it's a perfectly
for this patient, if you have a compliance of 8 in a patient who did a big start with big effort, you have intubated, the compliance is 65. I do use 8 or use 6, look at the PCO2. If the PCO2 go to 60, with 6, use 8 or even 9. Look at the plateau pressure, will be far from B30. The plateau pressure will be 22, 23, with a PEEP of 7, 8, because you don't require any big PEEP to correct a little bit the distribution of the blood. Remember, you don't have any recruitability in the L patient. And you have some recruitability, not tremendous, in H patient. Mm-hmm. You know what it seems to me, I don't have patient enough, but in a patient which look in the sequence in the CT, maybe they start L, they become H. When they start to recover from H status, you see that the big consolidation in the dependent region decrease, and you see back still the ground glass. So you see the virus behind that. Is very interesting, you know. Not pleasant.
And what it's tough because of the numbers, but like you said, I mean, there's always an opportunity to learn and understand also that people want dogma and want an answer. Give me a formula that I can apply to everybody and they'll be saved. And I think that type of magical thinking is very dangerous.
Yes, I'm afraid it's very dangerous. I mean, tell me why I need a doctor if I have to do medicine in that way.
Yeah. What about?
And tell me why I should use a standard therapy, let's see, ARDS, for an unstandard situation. Yeah. Why I have to use gasoline for a car which goes with diesel?
Yep.
Upgrade the car.
And Dr. Gattinoni, so I think that in terms of, I think the tidal volume, like you said, look at the compliance, look at the effort, very important. Look at the plateau pressure, all those things I think people have recognized. What about the PEEP? Would you think that the way to really, the way I've always thought about PEEP is use the least amount of PEEP that you need? Is that still true?
Stay in that line, which is perfect. The minimal amount of PEEP that you need. In this patient, if you're in an L patient, I think you can run easily with 7, 8 of PEEP without any problem. Because when I told you the compliance we measure, all the compliance, 78, were measured at 5 of PEEP. So in standard condition, when we measure that.
Interesting.
So I don't see any reason to have a 15 of PEEP, and I know that this may be a disaster. And anytime you play with PEEP, and I know that very few do that, look at the heart function, or look at the echo. When you increase PEEP, look at the right heart with the echo and see what's happened immediately. Or take a venous blood and look at SVO2. Or look how goes the plateau pressure. Increase PEEP, keeping the tidal volume. The plateau pressure rise as I rise the PEEP, rise more or rise less. And you have an idea what's going on. Yeah. And then set the minimum.
And I think that that's an important concept. You're not saying don't use PEEP, you're saying use the minimum amount of PEEP, because as you go to the H phase and you might have more recruitability and more like an ARDS picture, you might need a little bit, might need higher PEEP, right?
You may need higher PEEP. And the best thing is to make a test and to measure.
Yeah.
Because also in this one, you don't have we never observed so far spectacular recruitability. I say recruitability, not spectacular increase of oxygen. Yeah. Because increase of oxygen is another thing than recruitability. The oxygen may increase without any recruitability, as in air patient. The oxygen increase in prone position or with some PEEP and so on, not because of recruitability, but because of a flow diversion. The flow goes in areas in which the VAQ is more favorable. That's it.
So let me ask you, since you mentioned about prone positioning, that's been, I think, recommended, and a lot of people who have done it, including myself, have seen it. Basically, you have a response, but it's not as, the response requires proning for longer periods of times, which goes along with two observations you made. One is that this is a slow process in improving, and two, that perhaps the benefits of prone positioning are related to redistribution of blood. So obviously when you put them back supine, that redistribution changes again, and you have to prone them again. But you think that prone positioning, I mean, because of that mechanism, if it works, I mean, might be something to think about?
Well, I think as a rescue maneuver you can use. You don't have any way big damages with prone position, even it lacks in health patient the prerequisite to really be effective, which are the better distribution of stress and strain. But consider also that you have a lot of patients, having 20 patients, 25 patients in prone position may stress the nurses at a degree which you may avoid. Why? In the age patient, I think the prone position is absolutely correct, because prone position basically makes less dangerous whatever thing you do to the lung. So is some form of protection, the prone position. I would use as a therapy in in age patients. I would use as a rescue also to save the nurses in the air patients.
And what about people have proposed, and I've seen in some patients and with ABGs, non-intubated patients who, I mean, can self-prone or cooperative proning, and just telling them sleep on your belly, I mean, when you can, and checking the gases and seeing, I mean, a change. Obviously, it has to do probably with redistribution of the blood. But any thoughts on that?
Well, no, we have some of my colleagues had studied this problem, put it 30 and so on. So somebody will come out. My suggestion, ask the patient. Ask the patient, do you feel better in this position or in that position? It's very simple. He's not intubated, he's conscious, and he can tell you perfectly. Some colleague of mine told me that the patient say, oh, okay, I'm much better in this position. Some other patients say, no, I prefer the semi-recumbent position to the supine. Some patients increase in the supine position the PO2. The problem is that when you lose our regulation of blood, the blood follows the gravity, I don't know what, but it depends how the lung is compromised. And the blood goes to the gravity. But it's an interesting thing to study. Anyway, in prone position, usually the oxygenation goes up, at least for the first 4 or 5 days. Then the response for oxygenation becomes lower. In a patient non-intubated, I would put in prone position if the patient are very hypoxemic and maybe even overall are dyspnoid or start with some dyspnea, waiting for the bed and the intubation. I would ask the patient, because the patient is the better judge of his condition. I think in this situation, he breathes better or not.
Yeah, and in terms of steroids, I think that clearly for the L phase, I mean, probably the data would say don't use it in everybody. But now I think that some people have concerns with the effect it might have on viral pneumonias with prolonged viral shedding and replication. What are your thoughts, Dr. Gattinoni?
Let's see, because I don't want to give you the impression that from LH is just due to the doctors and so on. No? You may go from LH probably, even with what we call, what you think is the best treatment, because of the aggressivity of the virus and the host response. As everything starts with a reaction in the endothelial and with some cytokine storm. I have several colleagues who start to measure the cytokine. All the inflammatory cytokine goes up. The anti-inflammatory cytokine in some patients are close to zero, in some patients are activated. But I think if the logic of steroids and so on is to decrease the progress, the overinflammation, I would use at the beginning more than at the end. I would use in L phase to prevent a possible transit to the H phase. But I don't have any answer, because in my life I saw the steroids coming in and coming out so many times in 40 years that I stopped to believe to that.
Yeah. So I think that theoretically, I mean, that would be the argument. But like you said, I mean, so far we have not been able to show that really we should or shouldn't.
I have anecdotal response. If you see the patient, I think with 80 milligrams of prednisone, you didn't care anybody, okay? And so I think in some situation, I would not hesitate to try.
Yeah. Okay.
So we don't have to be so dogmatic, because there is some rational. I think if the patient is 6 to 2 weeks in mechanical ventilation with 35 of peak, 60 of PCO2, etc., you may give the steroids, but it's just for you, not for the patient.
Yeah. Exactly. And the last thing I wanted to ask you about treatment, and then we'll wrap up. And I'm really thankful for your time and your generosity with all your thoughts. It relates to obviously concerns about lack of ventilators or potential shortfalls in the numbers of ventilators. I mean, I know that there was a lot of talk about that in Italy. Now it's occurring in New York and in the United States. And I don't want to get into the ethical aspect. I think that's a conversation for a whole episode. But what about the thoughts of having more than one patient on one ventilator? It just seems that with a lot of things that we discussed and the potential for harm, that could be a very bad idea.
Well, I think that in one ventilator, let's see, you have the chance to kill one patient 50%. With two ventilators, I think the chance to kill two patients are 70%. Because or you know the physiology and the mechanical engineer so good that you use just the force of the ventilator for it, and you perfectly regulate the resistances, the diameter, the caliber. You choose the patient with a perfect similar compliance characteristic. But during the war, this does not work, I think. So I think that the double ventilator was, I think, patented 20 years ago in the States. But I think really is not medicine to me. Although I know that Kamarek, Brody, so very distinguished and very, very dear colleagues, they say, no, if you do the good protocol, good. But try to imagine how to wean the patient in double ventilation. Until you put the patient and keep paralyzed, you are just something, and you do like this, okay, maybe you can survive. But when you have to follow all the course of the disease, is very complicated.
Yeah, I think that's important because, like I said, I think with the anxiety that people have, everything that's new and different sounds like that's what we should be doing. And I think that people obviously are not thinking, what are the things that we understand? What are the things that we can apply? And how can we first avoid doing more harm?
But you know, by the way, it's not really so complicated. Because let's see, once we have decided to put a patient asleep, you put a sedation, paralysis. Avoid spontaneous breathing. Put 8 to 10 of PEEP after checking the hemodynamics and don't do absolutely nothing for 10 days. But the usual, of course, the usual care.
Yeah.
There is nothing to do. This sometimes is the problem. Nothing to do. Please don't go this, oh, I have to win. Ballooning, you don't have to win anybody at the moment because you make a disaster. I have to change if I do and to change. No, don't do it. Leave the patient in peace until the body wins the virus. What you do may be more dangerous than what you don't do.
And when you multiply that by the numbers that we're seeing, obviously the potential for harm raises exponentially, which is some of the things that I always worry about.
Yes, yes.
Well, Dr. Gattinoni, go ahead.
No, but just one consideration that I already did with another one. I think it's very irritating to hear somebody that saying, as I do now, do this, do that, suggest sitting in the office, relax with some water to drink, and good time outside. But believe me, you are in front line. In front line, sometimes it's very difficult to see the course of all the battle, which is easier when you collect a lot of information from different sources to make a story. So the story I told you is not just from one or two people. Is collected from several colleagues, and I didn't find anybody until today that told me, no, the patients described are completely different from what we have seen. Everybody sees this exactly the same patient. Depends the difference sometimes at the timing at which you see them. Therefore, it's fundamental to have an idea of the timing of the course of this damn disease, which is under the umbrella of ARDS, but to me, well, to call it ARDS, I have some difficulty. But let's call it as you want. There's no problem.
Yep. I think that's important. And like I said, I really appreciate your time. We traditionally close the podcast with a couple of questions that are unrelated to the topic that I think that what I found is that even in these very difficult times where people are very focused on a lot of what has not happened yet and trying to figure out how to deal with things, routine, I think, is always a good anchor to kind of bring us back to center. So would that be okay, Dr. Gattinoni?
Okay.
So the first question relates to books. And is there a book or books that have influenced you the most or that you have gifted most often to others?
Well, a good question. Well, there are several, I'm afraid. But the first that occurs in my mind is Siddhartha by Hermann Hesse and The Prince from Machiavelli, which is an unbelievably great book. If you want to be a chief, read The Prince.
And I think that one of them really focused on finding yourself and the other one on dealing with others. But I think it's a very nice combination. So we'll definitely put those in the show notes. The second question relates to what do you believe to be true in medicine or in life that most other people don't believe? And I think that the whole conversation has really centered around one of those things, but I'll let you answer it anyway.
That's right. I think that what is true in medicine is pathophysiology and physiology. And a lot of people do not, it's not that do not believe, but they do not know, which is even worse.
Yeah, I think that is something true that we see. I mean, a lot of colleagues in terms of how they apply not only these concepts, but also, unfortunately, how they interpret what's published, right? It's not evidence-based, it's just reference-based. And
That's
anything
right.
that's published in social media seems to have the same weight as a peer-review article in a high-impact journal.
What would you want every intensivist to know? Oh my God.
That's the
Well,
last one.
I think I would suggest to read 3 books, which are books of mono author. One is Respiratory Applied Physiology by Nunn. The second is The Pathway for Oxygen, Weibel, Function and Anatomy. The third one is Acid-Base and Electrolytes Equilibrium by Rose. All mono author, all the view of the same brain in a big problem. I don't like the books which are the collection of several authors. I prefer to read the soul of one single author in a single issue. These make my life different, these 3 books, in terms of profession.
So we will definitely link those to the show notes. Dr. Gattinoni, thank you so much for your time and for sharing with us your thoughts. I think that definitely a lot of wisdom and a lot of actionable things here for our audience. I hope you stay safe and that we have a chance to talk again soon, and hopefully maybe even see you next year, maybe in a conference in Mexico City.
Well, no, you be careful, huh? Because at the moment are you more exposed at the problem. But remember that the people who end up with H status are probably 1 over 500 or over 1,000. So the chances are very low. But you have to know it. Okay?
Absolutely. Thank you very much.
Thank you for listening to Critical Matters, a Sound Critical Care podcast. Make sure to subscribe to Critical Matters on Apple or Google Podcasts and share with your network. Sound Critical Care is transforming the way critical care is provided in hospitals across the country. To learn more, visit www.soundphysicians.com.